Clint, we're really excited to have you here today, and thank you so much for taking time out of your day to speak to us about your work.
Yeah, no. Thank you. Thanks very much for the invitation, Dr. Ogilvy. So um, let me get this started. And so I'm Clint, and thanks for the invitation. Happy to be here. I always start with this slide that has a disclosure that says, I have a different career path, and this is really for the residents and fellows. As Dr. Ogilvy mentioned, I don't know if Dr. Johns is on this call, but if you are, earmuffs, I'd much rather be an ablative head and neck surgeon. I loved head and neck when I was in residency. But I looked at my head and neck mentors at WashU, and I knew myself, and I realized that I couldn't do what they do clinically and also have kind of a real research program. I just couldn't do that. And so I thought to myself, what's something I can do clinically that would allow me to really protect my time? And I liked laryngology. And my first job was at kind of a joint appointment between Johns Hopkins and the NIH. And so for 6 years, I did 1 day a week of clinical laryngology. And in 1 day of laryngology with all those level 3-4 news and 31579s, I billed more than the head and neck surgeons did in the entire week. And what that did was it keeps the chair happy. It keeps your colleagues happy because you're not losing money. And the reality is, if you are passionate about research and you want to have a career in research, it's okay to make decisions like this to be able to set yourself up for what you want to do. Certainly no one ever told me that when I was a resident. And I had initially a lot of guilt about being a clinical laryngologist, with the intent of it protecting my time for research. But I think it's nice for the residents and fellows to hear that, if you're really passionate about something, it's okay to really design the decisions you make about your career around that to do what you want to do. It's my soapbox. What I'm going to talk to you today about is really what's happening with immunotherapy in the head and neck world right now. I've got no disclosures, no financial disclosures, although I do have to say I actually grew up near Bakersfield. I list that as a disclosure because that may make some of you completely discredit what I'm about to say for the next 40 minutes, and that's totally fine.
You ever go to the Crystal Palace, that Buck Owens restaurant? I
have. In fact, I grew up, I kind of grew up on a ranch outside Bakersfield. Our property was next to Buck Owens, and knew Buck fairly well because, and his sister Dorothy Owens, because my dad was a farrier, and my dad shoed Buck's horses, and we took care of his horses when he was kind of away. Actually, my most vivid memory of Buck Owens is he purchased the first off-the-line Dodge Viper. I don't know if you remember those cars, but they were like, when those cars came out, it was like,
that's cool. Yeah.
Look at this car. Yeah. I remember Buck would like drive around in the pastures of his property. And he was an eccentric guy. I put my thank you slide at the front of the talks just because I don't want to not be able to do it at the end. But I work at the NIH, and the NIH is, I might be biased, but I think it's the single greatest place to do basic or translational research in the world. And all of my success over the last several years is just related to being in this environment. And I think if you're here and you give a hoot and you show up to work every day and work hard, you can't help but be incredibly successful at this place. It's just an amazing institution funded by all of you. You pay my salary, so thank you. So I'm going to talk to you about kind of what's happened with particularly immune checkpoint blockade immunotherapy and head and neck cancer over the last several years. Really what the field is studying now as what's going to be the future of how immunotherapy is integrated into upfront treatment for head and neck cancer. I'm going to show you one data slide from one of our papers because I think it's important spending the minute that it would take to really go through this data to help you understand why we're starting to really learn some of the real mechanisms of why immune checkpoint blockade, particularly in the neoadjuvant setting, is going to be really important. So here's the token slide showing that the immune system is designed and has adapted to kill cancer. So you have a cancer, and this cancer outgrows part of its blood supply, so the central core becomes necrotic. These necrotic cells, here they're called pre-apoptotic, but it should really be necrotic. They release some of the stuff from inside the cells. Some of that stuff we call antigen, and some of that stuff is picked up by antigen-presenting cells, dendritic cells, which then take it to the lymph node where they present it to T cells. T cells are the adaptive arm of the immune system that have the ability to detect and kill cancer cells. These T cells go back to the tumor and they kill tumor cells. And so we know this happens. We know this happens in mice and people. We can experimentally prove it. So if this happens so well, why does anyone get cancer, right? I mean, how does cancer evade our immune system? And the answer is it's really complicated. But part of it starts with, you know, a tumor forms in the face of an intact immune system. So there's this immune selection pressure where the tumor cells that are least visible to the immune system are going to be selected for as that tumor develops. And in scientific terms, we would say there's going to be subpopulations of tumor cells that lack strong antigens. There are certain signals that are required for these antigen-presenting cells to properly take up pieces of the tumor and show them to the T cells, and sometimes those are lacking. Tumors recruit all kinds of immune cells because of the chemokines they produce into the tumor microenvironment. Some of them are good immune cells designed to kill tumor cells. Some of those immune cells that are also recruited are very immunosuppressive. And if you don't take anything away from this talk, you got to understand what immune checkpoint inhibitors are, or immune checkpoints and the subsequent inhibitors, and we're going to talk about that. So I just like to show this slide because it shows the complexity of what's actually happening at the microscopic level within a tumor. So this is a multiplex immunofluorescence of an HPV negative oral cavity squamous cell carcinoma. And we took the biopsy, we sectioned it, and we stained it with a bunch of different markers and fluorophores. And what you're looking at is all these big red cells. These are tumor cells that are coated in PD-L1, and we're about to learn what PD-L1 is, but all this red you see is cell surface PD-L1. And all these multicolored cells kind of throughout this tumor, these are all different immune cells. Some of these are T cells, which are the good cells that'll kill tumor cells. Some of them are macrophages or Tregs, which we think are immunosuppressive and limit the function of T cells. But this just gives you an idea of kind of a war that's being waged within these tumors, a back and forth between the tumor trying to grow and suppress immunity and the immune system trying to keep it at bay. And that's independent of all the stuff that we do to people, right? We give people chemotherapy and radiation and we cut tumors out, and there's just a lot going on. So this is the minimum of what you got to take away from this talk. This slide is the basis of immune checkpoint blockade immunotherapy, and you got to understand this. So here's your T cell, right? I've already showed this slide of how the T cell gets activated by being primed by the antigen presenting cells and all that stuff. Let's assume this T cell is activated and specific for tumor, and it shows up inside the tumor, ready to go. Well, when a T cell gets activated, it expresses PD-1, which is a receptor on the surface. PD-1 stands for Programmed Death Receptor 1. When T cells are activated, they also make interferon. These little orange dots are interferon. Interferon induces expression of PD-L1 on almost all the other cells in the tumor microenvironment. PD-L1 is the ligand for PD-1. And when T cells show up making interferon and drive expression of PD-L1 that then binds PD-1, it turns the T cell off. This is an automatic negative feedback mechanism. And this is one of the reasons why when we get a cold, we all don't die of autoimmune hepatitis afterwards. Our immune system is designed to be fast on, powerful, and fast off. And this PD-1, PD-L1 axis is one of the off signals for T cells. Well, tumors take advantage of this, right? They know that if they express PD-L1, often in response to interferon that's being produced by the T cells, this is one of the ways by which tumors escape killing by T cells. Some really smart people figured this out and made essentially therapeutic antibodies that bind either PD-1 or PD-L1 and disrupt this signaling axis. And this is everything. So Pembro and Nivo, from two different companies, they're a very similar antibody. They are PD-1 antibodies. Avelumab and durvalumab and a bunch of different mAbs, all from different companies, are PD-L1 antibodies, but all these antibodies essentially do the same thing. They bind and block the signaling through either PD-1 or PD-L1 to quote unquote take the brakes off of the T cells to reverse this negative T cell signal. Okay. So let's talk about kind of the paradigm of the clinical trials that have been done so far and how we treat head and neck cancer. So before 2016, we treated unresectable recurrent metastatic head and neck cancer with cocktails of chemotherapy. So here's a timeline of kind of what happens to, unfortunately, too many patients with especially HPV negative head and neck cancer. So you have an initial diagnosis. There's some period of time before you can have your definitive treatment, whether this is surgery followed by adjuvant or definitive upfront chemoradiation, but you have your definitive treatment. And unfortunately, depending on the type of cancer, there's a very high rate of either local regional recurrence or you develop a distant metastasis. And this is medical oncology language that surprisingly took me a long time to learn. This was very confusing to me. But when patients have developed a recurrence that is unresectable or a distant met, and they get systemic treatment, that first treatment, the medical oncologists call first line. Local regionally recurrent head and neck cancer that is unresectable or distant metastatic head and neck cancer is very hard to cure. Most people are not cured. So first line treatment very rarely cures people. So then they go on to second line treatment and down the line. So it could be third line, fourth line, whatever. But you got to understand this timeline because we're going to talk about the clinical trials that have been done with immune checkpoint inhibitors, particularly PD-1 inhibitors, and kind of where they fit in with the treatment paradigms. So first off, this paper from 2008, which to me, 2008 was the beginning of time because I didn't even do residency with Courtney until 2012 we finished in 2012. When I was a resident, this was standard of care treatment for patients that developed a unresectable local regional recurrence or a distant metastasis. This paper came out in 2008 in the New England Journal of Medicine. This regimen was called Extreme, which is as horrible as it sounds, but it was essentially a cocktail of cisplatin, 5-FU, and cetuximab, which is the EGFR antibody, and it worked this well, which is not very well. About a third of patients had a measurable objective response, which means their cancer shrunk a little bit on CT scan. Progression-free and overall survival weren't great. But based on this paper, this was the definitive standard of care of how we treated recurrent metastatic head and neck cancer until this clinical trial came out. Right now, if you see this red arrow on the timeline, the first clinical trials that were done using PD-1 inhibitors were done to explore whether they have efficacy in patients that have failed that first line treatment. So they've had presumably Extreme. It has not worked for them because it didn't really work for many people. And then when they were ready for their second line treatment, in this clinical trial, Checkmate 141, they were given pembrolizumab. This is nivolumab, sorry. So for the residents, when Courtney and I were residents at WashU, we had to memorize all the seminal clinical trials that led to standard of care treatment for head and neck cancer. So we were studying like the VA larynx cancer trial from Michigan and these like RTOG trials from Europe and stuff like that. These are the clinical trials that you're going to have to know, not only because they are now defining standard of care treatment for head and neck cancer, but because they're going to start showing up on the in-service and the boards. So one of them you got to know is Checkmate 141. This looked at nivolumab versus kind of dealer's choice standard of care chemotherapy. So after patients failed first line, patients were randomized to receive either nivolumab alone or like the cocktail of chemotherapy that institution or that medical oncologist happened to use for second line. And no matter what this standard therapy it was, nivolumab beat the socks out of it. So nivolumab monotherapy, not only did it have much less toxicity, but more than double the amount of patients were alive at 12 months. So this clinical trial is what led to FDA approval in 2016 of nivolumab for second-line treatment of head and neck cancer. At kind of the same time, Merck was sponsoring Keynote 012. This is another clinical trial you got to know, Keynote 012. This was a very similar clinical trial, but instead of using nivolumab to block PD-1, it was pembrolizumab to block PD-1. The objective response rate in this clinical trial was actually a little bit lower, but what they noticed was that patients who responded tended to respond for a really long time. In other words, if they didn't die of their disease, they actually lived for a really long time after getting the pembro. So the results of this clinical trial led to pembrolizumab getting FDA approved also in 2016 for second line. So we had a period of a few years where the standard of care was patients got first line extreme. And then when they failed extreme, it was really kind of institution and probably insurance company dependent on whether they got pembro or nivo as their second line. But the success of this clinical trial, pembro is Merck, made Merck say, oh, we got to fly with pembro and head and neck cancer. We want pembro to win in head and neck cancer. Merck has been winning because they have pumped billions of dollars into head and neck cancer clinical trials that you will see over the course of this talk. But this was the next clinical trial, Keynote 048, that essentially said, okay, if pembro works and is now FDA approved for people that have failed extreme, let's head-to-head compare pembro with extreme. Let's see if pembro can be used first after a patient develops an unresectable local regional recurrence or a distant metastasis, instead of them having to have extreme first and then fail. So you can see by the study design, that's really what it did, was it compared in patients with their initial treatment failure, they were randomized 1:1:1 to get either pembro alone, extreme, which was the standard of care, or pembro plus kind of a modified chemo. This chemo happened to be essentially extreme, but without the cetuximab. So it was the platinum and the 5-FU with pembro. So now you can see this red arrow. Now we're investigating how do these checkpoint inhibitors do in first line treatment. And so here's the results. So another thing, residents, you got to know is CPS, stands for Combined Positive Score. This is a histologic immunohistochemistry stain for PD-L1 that is now standard of care to be done by pathologists for every patient with recurrent or metastatic cancer. So if a patient comes to the ENT clinic and they have a recurrence or a metastasis, one of the goals is going to be to sample that tissue, and the pathologist should be doing combined positive score staining, which is a PD-L1 stain, because the results of that PD-L1 stain now drive what the treatment is. So what does that mean? So the results of Keynote 048 indicated that when CPS is greater than 1, in other words, some percentage of the cells in that tumor express PD-L1, pembro monotherapy is better than extreme. You might say, hey, Clint, these survival curves don't look super awesome, amazing. And I would say, that's right, they don't. But this is by far the most significant improvement in survival in recurrent metastatic head and neck cancer that we've ever seen in a clinical trial. If the CPS score is whatever, so independent of the CPS score, what that really means is if the CPS score is less than 1, if the CPS is 0, if there doesn't seem to be a lot of PD-L1 in the tumor, pembro plus chemo is better than extreme. And here's the survival curves. So what this led to was the state where we are right now in early 2021, which is if your patient develops unresectable local regional recurrence or distant metastasis, and they've received no other treatment besides for their initial treatment, you do a biopsy. If their CPS score, if CPS is greater than or equal to 1, which means there's some PD-L1, and by the way, here's what that stain looks like. This is from the Agilent website. Agilent is the company that makes the FDA-approved companion diagnostic for the PD-L1 stain. So your pathologists at UCLA are doing this, and this is what they're looking at. And so this brown honeycomb pattern, this brown color, that's PD-L1 on the surface of these are tumor cells. Some of these other smaller nuclei cells are actually infiltrating immune cells that can also express PD-1. But if CPS is 1 or greater, your medical oncologist should be giving these people Pembro alone. If the CPS is less than 1, your medical oncologist should be giving these people Pembro plus platinum and 5-FU, so Pembro plus chemo. And that's where we are right now. So Pembro is now FDA approved for first-line treatment for recurrent metastatic disease. And so the next question becomes, well, if Pembro works as first-line, why are we waiting till patients already fail? Why are we waiting till they develop a recurrence or metastasis? Are there ways that are safe and efficacious to combine Pembro with upfront treatment? And here's my schlick for otolaryngologists and surgeons in general. Neoadjuvant treatment is the concept of giving some kind of treatment before patients have definitive surgical management of their cancer. Induction treatment is giving some kind of treatment before they have definitive non-surgical, which for advanced stage head and neck cancer, we're really talking about chemoradiation. There are boatloads of medical oncologists in this country that do research, which means there are lots of medical oncologists who are studying this. Not a lot studying this. Take away what you want from that, but it's the reality. So I feel like it's really, I think our role as surgical oncologists to be advocates for our patients and do our due diligence, do the basic research and do the clinical trials that are needed to really investigate, is it best to combine these immunotherapies with surgery, or is it best to not? And I think we're the ones that have to do that. So people like Ravi Ubaluri and Bob Ferris have really led the way with this, and we're standing on their shoulders at the NIH, so to speak. So really the first clinical trial, and this was started when Dr. Volker and I were residents at WashU. This gentleman pictured here is Ravi Ubaluri. He was at WashU, now he's at Dana-Farber. But he really designed and executed the first neoadjuvant PD-1 clinical trial. In other words, he took newly diagnosed HPV negative advanced stage head and neck cancer patients. They had received no treatment, they're newly diagnosed, and he gave them one single dose of pembrolizumab, the PD-1 monoclonal antibody, before they had surgery. So you see now this red arrow at the bottom. We started with second-line trials, then we went to first-line trials, now we just keep moving up. That's the terminology we use, is we're moving the investigational agent forward to try to get better efficacy. What he found, and this was just recently published, if you haven't read this paper, you should, because there's lots of details in here and I'm not doing it justice. But essentially, this was kind of a single-arm exploratory clinical trial. But that patient population that he treated with a single dose of neoadjuvant Pembro, we know from historical controls and historical data that about 40% of those patients would be expected to develop a recurrence or a distant metastasis at the 2-year mark. And in patients that got a single dose of Pembro, he had a failure rate of 16%. So this was really and again, this paper just came out, but this was kind of the first published paper really indicating that there's a clinical benefit, that something is really happening to these patients with head and neck cancer when you give them Pembro in the neoadjuvant setting. So Merck said, oh, this seems like a good idea. And if we could give Pembro to everyone with newly diagnosed HPV negative head and neck cancer, that seems like a good business model. So the results of this clinical trial led to this clinical trial, which is now underway at multiple institutions really across the world. But this is a randomized phase 3 clinical trial that should definitively answer the question, does giving Pembro, and here they're going to do 2 doses before surgery instead of 1 dose, but does giving Pembro before surgery truly lead to improved local regional control and recurrence-free survival? Okay, I'm biased, but I think this clinical trial is going to be positive. I think a lot of people also feel the same way. So I think it's extremely likely that in the 3 to 4 year range from now, this clinical trial is going to release initial positive results, and Pembro will be FDA approved for neoadjuvant head and neck cancer treatment. And that essentially means that almost every head and neck cancer patient is going to get Pembro.
Can I ask you a question?
Yeah.
So you're given the antibody every 3 weeks. I mean, is that like the half-life of the antibody? Or
Yeah, yeah. All these dosing intervals were at least initially determined by antibody target binding saturation, which can be measured. And you're right. For lack of a better term, yeah, the half life is that. Now, Pembro specifically with Merck, they're starting to space out the dosing of the Pembro just to kind of make it more feasible for patients, because it's especially patients with hard way. If they live far away from an academic institution that's doing this, it's hard for them to come back.
yeah, does Pembro screw up the rest of the immune system, or is it somehow localized just for the cancer fighting T cells?
No, it's a good question. So Pembro and all these immune checkpoint inhibitors, they're very non-specific, right? What you're doing is you're taking the brakes off the T cells, and you're making some assumptions about the immune system being smart enough to understand what's tumor, aka what it should go after and what it should not. And so the side effect profile of these drugs is really autoimmune adverse events, right? It's your T cell immune system attacking something in your body that's not the tumor. And what we tell patients for our trials is really anything is fair game, like intestines, heart, lungs, skin, eyes, tongue, brain, really anything. But we've given these drugs to enough people that we've developed ways through good, complete histories and physicals and blood work to be able to start to detect when things that we don't want to happen are starting to happen. And if we pay close attention to people that are on these drugs, we can prevent severe immune-related adverse events that lead to patient harm in almost everyone. So initially in these first clinical trials, people were getting pneumonitis and dying because no one knew what that was or what it meant or how to watch for it. I mean, today you see a lot of people that, might get their thyroid gets knocked out and they might have to be on supplemental thyroid medicine, or their adrenal gets knocked out and they might have to be on supplemental hormones, or even their pituitary. But the rates at which people develop life-threatening pneumonitis, pericarditis, stuff like that, it's really plummeted because medical oncologists have gotten pretty trigger happy at stopping immunotherapy and putting people on steroids to reverse adverse events, which is probably the correct thing to do. That's a great question. So here's the one scientific data slide I'm going to show you. And I think it's worth taking time to go through this because this was preclinical work we did in our lab that we think sheds light on probably one of the many mechanisms that can help explain why does neoadjuvant immunotherapy specifically for head and neck cancer, why does that seem to work so well? So here's what we did. And you don't even have to look at the slide, I'll just explain it to you. So we took a cancer cell line and we engineered it to express multiple antigens. Antigens are the things, remember, that T cells recognize. And we put a really strong antigen that does a very good job at activating T cells and a weak antigen that doesn't do a good job. When we put those into a mouse and we study the immune response that happens to that tumor in the mouse, you get a dominant T cell immune response against the strong antigen, and essentially little or no immune response develops against the weak antigen. This is really problematic because cancers are filled with mutations, and mutations are what lead to the antigens, and some of them are strong and some of them are negative. And remember, we talked about this phenomenon where if you have a tumor where there's strong and weak antigens, you're going to get an immune response against the strong antigens, and it's going to kill all those tumor cells off, and what you're going to be left with is the tumor cells with the weak antigens. What we showed is that if you give a PD-1 inhibitor to a mouse that expresses these strong and weak antigens in a tumor, what you seem to be doing is selectively unleashing the activity of the T cells that are targeting the weak antigens, because those T cells, for reasons that we're just starting to understand, express a lot of PD-1, even more PD-1 than the T cells that are targeting the strong antigens. So by giving this immune checkpoint inhibitor before surgery, when all the tumor and all the antigen is still there, you're allowing that T cell system to develop what we call a polyclonal T cell response, where you're getting strong responses against both the strong and the weak antigens. But here's the kicker. If you wait until after you've already removed the tumor and you remove all the antigen, and then you give the immune checkpoint inhibitor, you might as well just be throwing rocks at the mouse. It doesn't do anything. So there's something about the antigens still all being there. In scientific terms, people here at the NIH like to say that you're using the cancer as a vaccine. You're using the cancer as the pool of antigen. And you got to like train the immune system what to go after, the strong and the weak antigens, before you cut it out. So this has huge implications, right? Because the medical oncologists are going to say like, oh, you just need to use, you know, the Pembro as an adjuvant, you know, we'll do the chemoradiation and we'll, you know, we'll give the Pembro, or you can cut the tumor out first, you know, and then we'll give the Pembro. All of the preclinical mechanistic scientific evidence from our lab and many others, there's a lot of people in Australia studying this, Japan, France, much bigger bang for your buck in developing a polyclonal T cell response if you give the immunotherapy before you cut out the tumor. Neoadjuvant immunotherapy. Okay. So in the big picture, does this make sense? And this is kind of my one theoretical slide, so allow me to theorize a bit here. But our immune system is designed. It developed a long time ago for infection, right? Our immune system did not develop to ward off cancer. Our immune system developed to ward off infection. And what happens normally in an immune system response to infection is your immune system detects the infection, and there's a strong, powerful response to the infection, and the infection goes away. What that means scientifically is the antigen goes away because you're getting rid of the infection. And then you get this contraction from the effector phase of the immune response, which is the kill the antigen phase, to a memory. And the only way that T cells will contract from the effector phase to the memory phase is if the antigen is gone. Another way of saying that is probably the most immunosuppressive thing you can do to the immune system is to have persistence of antigen, have antigen that stays around and doesn't go away, because you never get contraction from the effector phase to the memory phase. And when T cells are chronically in the effector phase, they become what we call exhausted. They just stop working because they can't be continuously on. Cancer is the pinnacle example of antigen that just stays around unless you do something to it. So what's the one thing you can do to cancer that mimics what happens during an infection? What's the one way with cancer that we can activate the immune system and then remove the antigen to allow the immune system to have the powerful response it's supposed to have? And I can think of no other way of doing that other than with neoadjuvant immunotherapy to get the activation, and then you remove the cancer. You certainly don't do it with 7 weeks of chemotherapy and radiation. That certainly does not immediately remove the antigen. Now, I'm not saying that the case is closed on whether immune checkpoint blockade or other immunotherapies can be effectively combined with chemoradiation, all that stuff. There's lots of medical oncologists that are studying that. But I'm making the argument that our best scientific data so far suggests that we get the best anti-tumor immune response when we manipulate the immune system in a way that mimics how it was evolutionarily designed to work, which is get rid of antigen and contract from effector to memory immunity. And the way that we, with our current tools, can do that is to give neoadjuvant immunotherapy and then remove the tumor. So I think from a big picture standpoint, this makes sense. So Ravi Upaluri and Bob Ferris and other people have really led the way and done the seminal initial work in these neoadjuvant immunotherapy trials. The one paper I showed from Ravi is the one that's been published so far. We are about halfway through this clinical trial at the NIH. I have the viewpoint that Keynote 689 trial, which was, you know, the big international trial that Merck is sponsoring to look at neoadjuvant PD-1, I think that's going to work. So I think any other clinical trial that we in the field do that is not looking at something that's more than Pembro. Like, to me, the question 3 years from now is going to be like, is there anything better than Pembro? What's better than Pembro? So the way that we've gone about that is we're doing a very similar neoadjuvant clinical trial. So newly diagnosed cancer patients are going to come in, and they're going to have, they're going to be surgical patients, so they're going to get surgery. But before they have surgery, we give them, these are just different drugs. I'm not even going to go through what these drugs are, but they're different versions of immunotherapy that are something more than just Pembro. The other advantage to doing these neoadjuvant clinical trials is you're really guaranteed to have pre and post treatment tissue, which is it's a huge luxury and a huge advantage, because in a lot of clinical trials, you don't have tissue to study. So we're going to do the most amount of science that has ever been done in the history of any clinical trial on Earth on these samples. We're culturing T cells out of them. We're doing single cell sequencing of the tumor cells and the T cells. We're just doing all kinds of amazing things. And I have some of these results, but I medical legally can't show you them yet, so I'm sorry. But I thought what I would do is show you kind of one example of what this clinically can look like when you give a patient neoadjuvant immunotherapy, and some of the lessons that both Robbie Upalerdi at Dana-Farber and Bob Ferris and us and some other institutions, particularly on the East Coast, are starting to learn about what are some nuances and some interesting things that happen when you give someone with a surgically resectable cancer neoadjuvant Pembro. So I'm going to show you some clinical photos of this. A 65-year-old former smoker drinker. She's got a clinically and radiographically staged T3 and 2C. So it's kind of, inner labial mucosa. Here's where the cancer started. And so this is before we've given her inner treatment. This is really at the time of diagnosis. You can kind of see this bulge, so clearly this cancer has invaded deeply into that lip, and you see this bulge here. I'm sorry some of these pictures are kind of blurry, because I think she took selfies at the mall or something for some of these photos with her iPhone. But so here's pre-treatment. We gave her 1 dose of this immunotherapy drug, and 3 days after, it started to get red. And I would make the argument this is more swollen than this. 4 days after, this thing, as a clinician, I would look at this and say, it looks like it's pussing out. It looks like it's like an infection or an abscess or something, and it's coming to a head. And between the 4th and 5th day, it kind of popped on its own. It erupted, and stuff started draining out. And then it started to kind of dry up over, to the point where it is now at day 14. But even here, she's 2 weeks out from her first dose of Ventra. And I would argue this is still red and swollen compared to this. Now, we said, oh my gosh, we caused an infection. This is terrible. It's going to be an immune-related adverse event. We're going to have to report to the FDA, and they're going to close down the trial. But we we cultured this, no bacteria. She never had a fever. She never felt bad. All of our objective measures was this was not an infection. And so this is the surgical H&E. This is the surgical slide from her definitive cancer surgery. And this is just incredible to look at. So here's my other pointer real quick for the residents. You learn so much by looking histologically at a tumor. And if you're in a case and you ever have the opportunity to go down the path with like a frozen section or something like that, do it and learn from the pathologist. You're going to learn something about the cancer that you're operating on. And that's a better use of time than sitting in the OR waiting for a frozen, talking about your favorite Michael Bolton songs or whatever we do in the OR. Go down and meet with pathology and learn something. You can learn so much, even just from a simple H&E. So this is, imagine her lip. You just cross-section through the cancer of her lip. So here's the skin side. You can tell this is the skin side because this is keratinizing mucosa, right? You can tell this is the inner side because it's non-keratinizing. But essentially, this is where her cancer started. There's a big crater. This big kind of dark purple thing is the cancer, and you can see where it erupted through on the outside, and that's where she formed that head, and then it popped. This is obviously after she's had the immunotherapy, and the entire inside of this tumor just became necrotic and liquefied, and that was that fluid that built up and popped out. This is a cytokeratin stain, just showing exactly where the cancer is. So everything that's brown here is a cell that expresses keratin, which is the squamous cell carcinoma. I think we have time. I'm gonna show you a couple more slides, and I'm actually gonna pull up the actual H&E on the software that we use to look at this. And I'm gonna zoom in and I'm gonna show you some really interesting things. It's just amazing what you can learn from these tumors just by looking at the histology. This is her neck disease. So she had this kind of, right high level 2 and large lymph node. This was FDG avid. I forget what the avidity was, like 10 or something. And this was FNA proven squamous cell carcinoma. She also had this left-sided lymph node kind of between her great vessels. This was not biopsy proven, but it was FDG avid. So we staged her as N2C. This is pre-treatment. This is post-treatment. Sorry, the contrast isn't as good. If anything, this lymph node got bigger. So what we're seeing is that we give these people neoadjuvant immunotherapy. Their tumor kind of even like gets bigger. And on pathologic analysis, this patient was N0. And what I can tell you is from the first 14 patients we've treated with this immunotherapy, we've had 10 of them with biopsy-proven neck disease. And in 5 of those 10, where we know they had disease in the neck to start with, they are N0 on final path. And that's incredible. I mean, when you can give someone a neoadjuvant immunotherapy and induce disease regression to the point where with appropriately done clinical trials down the road, we might be talking about sparing patients something like radiation or something like that. This is really what we're going for. So some caveats from this is these tumors, we haven't seen a tumor shrink yet by CT imaging in that window that they're getting the neoadjuvant immunotherapy before they have surgery. So this concept by the medical oncologist of like following changes by scans just doesn't apply with neoadjuvant immunotherapy. If anything, they seem to get larger. The scientific analysis of these tumors in these bloods is going to teach us a lot about mechanism, and we're going to do crazy cool science and all this stuff, but I would argue this is the only thing that matters. The only thing that really matters, and the only way we're going to know whether the scientific and the immune correlate changes that we see, whether they mean anything, is recurrence-free survival. So all these neoadjuvant clinical trials are going to take time to mature, because no matter what happens in the short term, it's cool and it's scientifically interesting, but the only way it's going to mean anything is if patients' cancers don't come back. So if recurrence-free survival is improved, that's what's going to get neoadjuvant Pembro FDA approved. That's the last slide that I had. What I was going to do, just because I think it's really interesting and it's cool, is I was going to pull up this actual H&E, and let me just share my screen real quick. So here, we can zoom in on everything. So here's kind of a full view of the lip, so you can kind of get a better view. Like here's the top of the lip, the keratin sticker here, which is why your lip has a different color than your skin. But here's a nesta tumor. Here's the big tumor that's kind of going all the way through the lip. But if you zoom in on this stuff, it's just incredible. This was all like liquefied necrosis, keratin debris of the tumor just dying. And that doesn't happen on its own. Like a tumor doesn't grow and progress and just liquefy and die on its own. And if you look at, for example, this section, you can kind of tell the difference. These big, huge cells with big nuclei that look like eyeballs, these are all the cancers. These little cells with darker, round nuclei, these are all immune cells. And if you scan around to different parts of this tumor and you look, it's pretty easy to train your eye to realize that these cancers are just being massively infiltrated with the immune system. And I'm sorry I don't have this patient's pre-treatment sample. We have it, but one of our servers wasn't working this morning. We're probably being hacked. But this patient doesn't have this robust immune infiltrate pre-treatment. And this is a very consistent pattern that we see. So I think it's just really cool to just look at these cancers, and you can learn so much just by looking at the histology, and there's just immune cells everywhere. we have every toy available to us in the world here. So we're going to do all these stains and single cell sequencing, and we're going to know exactly where the TCLs are and all that stuff. But anyway, I'm going to stop nerding out. So we've got 10 minutes left. I'm probably going to leave this up just because I think it's more interesting to look at than me, but I'm happy to answer questions or talk about what we're doing at the NIH or anything anybody has. And thank you very much.
Clint, hi. I'm Uttam Sinha, one of the head and neck surgeon here at SC. Great talk, really enjoyed. So what do you think about cell-based therapy versus this kind of targeted therapy?
Yeah, good question. So when we talk about cell-based therapy, right now, what we're really talking about is taking a patient's own T cells and engineering them to either express a CAR, which is a chimeric antigen receptor, or a TCR, a T cell receptor. And so it's important for people to understand the difference between those two. So a TCR can recognize an antigen that came from inside the cell and is presented on MHC class 1, whereas a CAR is essentially a modified antibody, and all it can detect is a protein on the cell surface. It's just like an antibody. So the problem with squamous cell carcinomas, as opposed to blood cancers, which are very clonal, right? Like you can have like a B cell lymphoma, and every single cancer cell expresses like, B20 or whatever the antigen is. You can target those with a CAR because there's something on the surface. The squamous cell carcinomas, first of all, they're very inconsistent in their protein expression on the surface. And even if they were consistent, chances are there's something on that cancer cell that's also on like every other epithelial cell in your body, like EGFR or something like that. So if you used a CAR that targeted that, the assumption is there'd be massive toxicity. So really for epithelial cancers, where the antigens are derived from mutations inside the cell, your only real option probably is doing TCR engineered cell therapy. So I think cell therapy is very powerful, but each TCR is specific for a given antigen. So for HPV cancer, where we know what some of the antigens are, like we think every single cancer cell in an HPV cancer expresses at least E7 and probably also E6. You can have a TCR that targets E7 presented on some HLA molecule. And in fact, here at the NIH, we've discovered and done the initial clinical trials on both an HLA-A02 restricted E6 and E7 TCR. And that's promising. But since most antigens that the immune system is targeting come from mutations, we call those neoepitopes. Unfortunately, each cancer patient's neoepitopes are different because they come from the mutations, and the mutations are unique for that patient's cancer. So we probably are going to be in a situation maybe 50 years from now or something like that, where you can sequence a patient's tumor, know definitively from bioinformatic analysis what the neoepitopes are, and then either design synthetically or be able to isolate TCRs for those patients' specific antigens and then re-engineer their immune system to be really perfectly specific for the cancer, but we are nowhere close to that yet. So what we're left with is the option of these kind of more non-specific immunotherapies, where we're kind of relying on the immune system being smart enough when we take the brakes off to go after the cancer.
Probably it would be good to do for HPV positive, as you mentioned, E6, E7 protein, and targeting them. Probably would be, we can have a cassette of a group of antigen, and maybe we can target those with the cell, with the engineered T cell.
Yep. Also probably EBV,
Right.
nasopharyngeal cancers. We without saying too much, we think we've discovered a HLA-A02 restricted EBV specific TCR, but the problem is that most persons with Asian background are not HLA-A02. Most of them are A11. So what we really need to find is an A11 restricted TCR, and we're trying. But yeah, all great comments.
So offline, we'll talk offline about collaboration with our cell therapy and other areas.
Cool. Yeah. No. Thank you. The other what I'll say is the other kind of version of cell therapy that's coming along is NK cell. based cell therapy, which is kind of in its early stages of clinical development. But you can do all the same things to an NK you can do to a T cell. You can actually put a CAR on NK cells just as well as you can put them on a T cell. So there's some advantages of NK cells, but that's kind of a whole nother
So we're mounting the IL-12 and IL-15 on the surface, and whether they can take it to the tumor.
Yep.
And attack it.
Yep. No, it's all really lots of possibilities.
Yeah. Thank you.
Clint, that's super. Mike Johns here. Thanks so much for joining us. Super impressive work, and great to see you, of course, and hear from you. Really interesting to see the overlap and kind of connections between your work and in papilloma, and was thrilled to see the new RRP trial that you're starting. We've got flyers in our clinic about it, and I've already sent a patient your way for it.
Yeah, no, I thank you. Good to see you too, and thanks for mentioning that. Yeah, it's a really unique situation where we have the opportunity to take all this advance and knowledge that's happening in the cancer world and really apply it to something that, frankly, you and I understand the cancer world at large doesn't give a hoot about RRP, but, clearly we as otolaryngologists do, especially as laryngologists. So it's, I certainly didn't start off my research career thinking that I was going to do anything with RRP. I thought we were just going to be a straight cancer lab, but it's been an extremely gratifying part of what we've done to build up the RRP program here. I mean, I remember when I first got here, I mean, these are like world famous scientists and immunotherapists here at the NIH, and you're like teaching them what RRP is, because it's not in the national mentality. Like no one knows what RRP is. So, but thank you for mentioning that. And we're excited about the next trial. Yeah, I think we're going to cure RRP. I think we're going to do it.
Clint, Niels Kokot. I'm also one of the head and neck surgeons here. Great talk. I just wanted to ask you about margin assessment. And so when I, as a resident, first reading about a lot of the neoadjuvant trials that came out of France with Olivier Lecourrier, they'd take methylene blue and mark the edge of the tumor, and then they'd give him cisplatin, and they'd go back to their methylene blue and cut out the tumor and get adjuvant treatment. So what is your thought on the patients that do get regression of their tumor, and when you give them the immunotherapy, then you go in to make your tumor cuts, and let's say the patients don't need adjuvant treatment, what about that intervening margin between where the tumor was originally and where you make your cuts after regression of the tumor?
Yeah.
And in that patient that had a complete response to in the neck, they would normally get radiation. Do those patients still need adjuvant treatment?
Yeah, these are all really great questions and difficult ones that are especially challenging for us here at the NIH. So the way that our neoadjuvant trials work is, the NIH, I think, is the best place in the world to do science. I would argue the NIH Clinical Center is probably the worst place in the world to do a oral tongue resection with a radioform flea fiber reconstruction and bilateral neck dissection. We don't do standard of care well. So we have this relationship, right, where we have Hopkins Suburban Hospital across the street. So we actually do the immunotherapy here, and then we do the standard of care component of their treatment across the street at Suburban under the auspice of Johns Hopkins. So the way we do it is when we do the surgery based on the surgery the patient would have had if they had never been on the clinical trial. So even if we haven't seen this yet, because most of the time the tumor kind of swells or the lymph node swells, but even if we saw what we thought was complete regression of the tumor in that 4-week period before surgery, we would still go based on the original margins, based on imaging, or sometimes we have one of our surgeons that'll take the patient and do like little methylene blue dots, around where the original margins would have been. Because really that's the only way that you can assess what your pathologic response is. And one of the outcome measures of all these neoadjuvant studies is their clinical to pathologic downstaging. And again, I emphasize, we don't know what that means right now, but 3 years from now, when we've treated, 1,000 patients with neoadjuvant immunotherapy, it may be that there's some correlation between clinical to pathologic downstaging and improved recurrence-free survival. But unless we do the original surgery as it was intended to, we're not going to be able to get to that answer. So that answers the first part. The second part about the adjuvant treatment, one thing that's unique about the NIH is a clinical trial we do here cannot dictate standard of care treatment to an academic institution. So what we tell when we put our Hopkins hats on and we take our NIH hat off, we decide adjuvant treatment based on pathology per standard of care. So if the original staging was T3N2C and we do the surgery and there's no perineural, margins are negative, there's no high risk features, and they're T3N0 and the patient doesn't need radiation, they don't get radiation. So we tell everyone, act like they never did the trial, do your surgery, and whatever the pathology tells you the adjuvant should be, that's what you should do. And that's what Ravi did at the Dana-Farber WashU study. That's what Bob Ferris has done with the Nevo study. I think that's what they're doing in South Carolina and Jefferson and all the places that are doing these trials.
So that's an interesting approach, because that's a little, when we talk about how we're treating patients between like HPV positive patients between AJCC 7 versus 8, we stage with 8 and we treat with 7. So it'll be interesting to see how that all evolves, as we learn more information about the de-escalation trials and patients are doing, HPV positive patients are doing so well because we're treating based on, 7th edition staging, even though they're downstaged. So it'll be interesting to see, and if you guys are seeing that you can treat adjuvantly based on what your pathology is versus original staging, it'll be interesting to see how that translates to HPV positive patients as we learn more about the de-escalation trials.
Right. No, that's a good point. I mean, we get asked this question a lot, and the general language we use is we're not to the point yet with HPV negative cancer where the outcome measures of the study are de-escalation.
Yeah, of course.
We still do crappy with HPV negative cancer. So we're to the point where with HPV negative cancer where we're doing the trials to try to figure out, can we make recurrence-free survival better? Once we know that, then we could start to have the conversations like we're having with HPV positive, where can we like truly, like in a protocol, dictate de-escalation or whatever. So
well, I mean, the HPV negatives, if you consider, a stage 4, which is a lot of patients, 5-year survival at 40% or less, which is sort of the, traditional standard. If you could move that even, anywhere higher than that, that'd be a big improvement. So, I mean, if you were, that first slide, I think you showed, Ravi's data of 16%. Versus 40% 2-year recurrence. I mean, that's huge. That is huge. That'd be a big difference.
Also, it will be interesting to rejuvenate the T cells through microbiome. That's another area we really need to study. How we can make it much healthier, and through probably liquid biopsy, we can look at the cells whether they are getting more healthy.
Yeah, we always joke around here that we're going to be doing fecal transplants on everyone before head and neck cancer surgery, but I don't know how powerful that is.
Okay.
Hi, one more quick question, if it's okay. So I'm Mark Swanson, another one of the head and neck surgeons. So you were talking about using the checkpoint inhibitors preoperatively to kind of use the antigens as a vaccine while they're there. Is there any role in using a tail after definitive treatment to kind of keep the immune response high and get some of the surrounding dysplasia or perineural invasion that may have been out of the resection margin? Or is kind of the preoperative checkpoint inhibitor have a lasting effect afterwards?
Yeah, that's a good question. If you worked for Merck, you would say you need to give it for a year. Which may be the right answer. All that I can say is the scientific data we have so far suggests that you get your most bang for the buck with the neoadjuvant. Now, having said that, that Keynote 689 trial is designed to continue on and give adjuvant Pembro as well as the neoadjuvant. And, I think most of us can probably recognize that was a drug company decision. That wasn't based on any science. So I don't know. I mean, that Keynote 689 should answer the question of whether neoadjuvant plus adjuvant leads to improved recurrence-free survival. My assumption would be that the follow-up study after that we might be doing 5 years from now, if Merck has made enough money on Pembro that they're willing to let us do the study, would be comparing whether neoadjuvant without the adjuvant gives you the same improved recurrence-free survival. I don't think there's really a clinical trial ongoing right now that's designed to answer that question. But scientifically, the answer to me is you don't need adjuvant. It's all about the neoadjuvant.
Thank you.
Thank you.
Clint, thank you so much. That was really an exciting talk and very understandable for somebody that doesn't do a lot, head and neck. So I personally appreciate it.
Thank you.
Next time you're here, we will meet in Bakersfield and we will go see some country music.
No, we should meet in LA. We should.
All right. Well, thank you very much.
Thank you, guys.